Well, good afternoon, everybody. And I'm personally grateful to my colleague, Professor Muzzam, President, Pakistan Society of Hepatology, Professor Zahir Yaseen Hashmi. Does not need any introduction. Has served and still serving gastroenterology, hepatology, and medicine in general with great distinction. Professor Altaf is very active, vibrant professor of medicine and gastroenterology. Professor Javaid Farooqi, tireless individual, proponent of new ideas, and Dr. Arslan Shehzad, my assistant professor and very hardworking professional from our Pakistan Air Force Hospital. As we all know, the World Hepatitis Day is being, I won't call it celebrated, recognized on 28th of July, but because of COVID influence and all constraints we are facing, so we are on webinar. And I appreciate the efforts of Getz Pharmaceutical putting this show and enabling us to be together and then sharing our views. What we are going to do this afternoon is there will be two talks, and I'm not.
Jesus. Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am Dr. Salan. I am Assistant Professor Gastroenterology. I introduce you all with our panel of experts. Our first panel of experts is Professor Altaf Alam. He is ex-head of department and professor of gastroenterology at Sheikh Zayed Hospital, Lahore. He is working as consultant gastroenterologist at Evercare Hospital, Lahore. Our second expert panelist is Professor Zahir Yaseen Hashmi. He is former principal of Punjab Medical College, Faisalabad. He is the chairman of Liver Foundation Trust and is the in charge of Liver Center, Faisalabad. Our third expert is Professor Mauzam. He is the former professor of Civil Hospital, Quetta. He is the current president of Pakistan Society of Hepatology. We have two distinguished speakers. Our first speaker is Professor Javaid Iqbal Farooqi, and our second speaker is Professor Muzzafar Lateef Gill. To start our session, I would like to invite our first speaker, Professor Javaid Iqbal Farooqi. Our first speaker is Professor Javaid Iqbal Farooqi. He is ex-head of department, medical unit, Lady Reading Hospital, Peshawar. He is the former president of Pakistan Society of Hepatology. Currently, he is working as hepatologist at Al Hayat Clinic and Research Center, Peshawar. His talk is on hepatitis elimination, the way forward. So may I request Professor Javaid Farooqi Saab to kindly present.
Well, thank you very much for this kind invitation. The topic to me is the hepatitis elimination, the way forward. I'm thankful to Getz Pharma and my colleagues to give me this opportunity. As said by Professor Muzzafar Lateef Gill, the World Hepatitis Day is one of the WHO's 7 officially mandated global public health days. It is named World Hepatitis Day and is held annually on 28 July, which is the birthday of Dr. Baruch Blumberg, who discovered the hepatitis B virus in 1967, and 2 years later, he developed the first hepatitis B vaccine. These achievements culminated him winning the Nobel Prize. So that's the reason this is the 28th July is held as the World Hepatitis Day. The target audience for this talk is the doctors, from primary care physicians to consultants. There will be stuff for our nursing and paramedical staff as well. Some food for thought for government officials, as well as for the society key opinion holders and general public. So in my talk, there will be switch of mode of the themes and talks to very simple to a high technical one. So please bear me out with that. We all know that the hepatitis is one of the major health problems in the world. And the causes for this hepatitis, they are the viral hepatitis, which are named from A to E, A, B, C, D, and E. We all know this. And all these, they can result in damaging the liver, the healthy liver, extremely and leading to liver failure. But we know that the common causes of the acute liver failure are hepatitis A, B, D, and E. These are the worldwide. In addition to causing the acute liver failure, what they can cause, especially the hepatitis B, C, and D, these are three ones who can make the healthy liver through acute hepatitis to chronic hepatitis, resulting in the liver cirrhosis, when the liver is shrunken, and ultimately the liver cancer develops. So these problems we do see in clinical practice, cirrhotic patients with hepatic encephalopathy, with bleeding, they vomit blood, the hematemesis melena, the ascites and its complications, the liver cirrhosis, the cancer, as well as the hepatorenal syndrome. So these are the complications of chronic liver disease and cirrhosis, which we see. And the chronic liver disease, we'll see later on, is one of the major mortalities in the world. If we take the hepatitis A, it caused approximately 7,000 deaths in 2016 around the world. Almost everyone recovers fully from hepatitis A. This is a good point, with a lifelong immunity. Very small proportion of people infected with hepatitis A who die from fulminant hepatitis. We all know that a safe and effective vaccine is available to prevent hepatitis A. It is transmitted through ingestion of contaminated food and water or through direct contact with an infectious person. The risk of hepatitis A infection is associated with a lack of safe water and poor sanitation and hygiene. Safe water supply, food safety, improved sanitation, hand washing, and hepatitis A vaccine are the most effective ways to combat this disease. Coming to the another orophycal route hepatitis, that is the hepatitis E. It caused approximately 44,000 deaths in 2015 around the world, 440,000 rather. Every year, there are an estimated 20 million HEV infections worldwide, and it leads to an estimated 3.3 million symptomatic cases. A vaccine to prevent hepatitis E virus infection has been developed and is licensed in China, but it's not available everywhere. Just like hepatitis A, it's also transmitted through fecal-oral route, principally via contaminated water, and that's the reason we see the epidemics. Hepatitis E is found worldwide, but the disease is most common in Southeast Asia, India, Pakistan, Kashmir, and here. Safe water supply, food safety, improved sanitation, hand washing, these are the most effective ways to combat this hepatitis E. Coming to the hepatitis B, C, and D, 325 million people today, they are living with the viral hepatitis B and C. 290 million, that means 9 out of 10, the dilemma is these patients that don't know that they have got this hepatitis B or C. This is a big chunk. And that's the reason the theme for this World Hepatitis Day is Find the Missing Millions. Annually, 1.46 million people die. It means 400 deaths per day. It is transmitted through injections, blood transfusions, surgical interventions, tattooing, ear and nose piercing, sexual route is another one, from mother to child in case of hepatitis B. We all know that a safe and effective vaccine is available to prevent hepatitis B. And that's the reason the hepatitis B vaccination is one of the components of WHO Eliminate Hepatitis program. Disposable syringing from injections, safe blood transfusion, safe surgical procedures, tattooing, ear and nose piercing, safe sexual HBV vaccination and prevention from mother to child. These are the effective ways of prevention of hepatitis B, C, and D. Why there was need to launch the hepatitis elimination program? The reason is in 2013, this is the mortality report by WHO. This is the patients dying. The green is the from acute hepatitis A, B, and E. And then this is the number of deaths, 4 lakhs around from B cirrhotics and C cirrhotics. And on top of this, these are the deaths from the petrocellular carcinoma. So in total in 2013, around 7 lakhs from hepatitis B, and the same number, rather a bit more than that, a patient died from hepatitis C. This is 2013 report. And in 2015, in the second report, again, very huge mortality from hepatitis B, hepatitis C, cirrhosis. So that's the reason. And this is the another graph, the data of WHO from 2000 to 2015. This is the red is the HIV mortality, and now this is on down slope. This is the tuberculosis mortality over years going down. This is the malaria mortality over years going down, but hepatitis mortality was rising. That's the reason in 2015 and 16, the WHO properly launched the elimination. In 2015, UNO included hepatitis in its sustained development goals. And in 2016, the World Health Assembly adopted the Global Health Sector Strategy on viral hepatitis to eliminate hepatitis from the world by 2030. And the goals of this Global Health Sector strategies is to reduce hepatitis incidence from 6 to 10 million cases to 0.9 million cases, and to reduce the annual hepatitis deaths from 1.4 million to 0.5 million by 2030. This is the more simple graph to understand. This is the reduction in the new cases by 90%. In 2020, it's around 30, but by 2030, the reduction should be to 90%. And the deaths, it's from 10%, the reduction should be to 65% reduction in the deaths by these hepatitis by 2030. And how we will achieve? If we achieve that 90% of people infected are diagnosed, as I said before, only 10% they are diagnosed. So if the total 90% are diagnosed, and if the 80% of those diagnosed, they are treated, and 90% coverage and vaccination, and 100% of blood products are safe, and 90% injections of the health facilities are safe. If we can achieve these targets, this will be achieved. So this is the in lump sum or in nutshell, the goals of the WHO set for the world countries. Just to understand the global hepatitis elimination, this is a model to make it understand. This is the hepatitis pool in the world, and this is the source of infection, reinfection for the non-infected people. So they enter the pool, and the people, they go out of this pool, they exit the pool either by the cure in hepatitis C or controlling the disease by hepatitis B, or they die. So how to reduce this from this big pool to this one by 2030? We have to have two strategies. One is elimination by prevention. So we prevent the entry of the new patient into this pool. And second is elimination by cure. So we cure more and more patients, either cure or we make them virus controlled or free in case of hepatitis B. So this pool will shrink down and will be lower down to the desirable level. These are the two components of global hepatitis elimination program. So one is the cure, one is the prevention. In the cure, as I said before, that this is what is the current situation, that out of all infected people, this fragment is tested. This is their condition is stable. These are included in care, and only this almost 20 or less than 20%, they are followed up. So what we should do, proper testing, linkage to care, then the treatment and the chronic care, and the prevention will go side by side throughout the whole this last 1 decade. On the cure side, 4 main components: blood and injection safety, harm reduction, 3 doses of hepatitis B vaccination, and prevention of mother to child transmission of hepatitis B. So these are the components of global hepatitis elimination model given by the WHO. And this is the situation that B vaccination is good. From mother to child transmission is less than 40%. Blood safety, many countries they are following this. Injection safety. So if I transmit this into more simple words, in 2015, the B vaccination will be increased from 84% to 90%. Similarly, the mother-child transmission, blood safety, injection safety, and all these things. WHO is regularly monitoring. They produce the document in 2015, 17, and then in the 19. What's the global progress? In 2017, the 135 people, they responded to this program. 84 countries, they had reported that they have got the hepatitis national plan, and 62 countries reported that they have got civil society engagement. And as February of 2019, the number of countries with national plan is really increasing. It is now around 130. So this is a good global progress. And this is a very important slide. Those countries who have engaged civil society in their national action plans, they're performing better as compared to those where only the governments they are doing it. So we should engage the civil society in this. What is the way forward? This is the most important point. As I said, keeping this model, we have to put our efforts on both ends. An elimination by prevention side, safe injections, safe blood transfusions, safe intervention, the surgical interventions, dental interventions, gynae procedures, safe sex we should promote, and HBV vaccination. These are the 5 main components we in Pakistan as well as globally we should work on it to achieve these targets. Coming to the elimination by cure, we should make the testing available and reliable to each and everyone at the doorstep. The linkage to care is important, and we should augment the healthcare system. We should improve the healthcare system. The treatment should be affordable, and it should be, the people should adhere to it. And the chronic care of the surveillance and prevention, these are the 4 main components on the cure side, which we should need to implement and into our national program. The affordability is the one of the major hindrance in getting all patient tested and treated. Every patient has the right that he should be linked to the testing, to the care, and to the treatment. So this is very, very important. And this is where the government and the civil society can join hands and work on it. So to elimination by cure, it has got 2 main components: treat the known cases, and I already said how, reduce the barriers, to develop ancillary skills and services, linkage to local community-based organizations, benefits, consider counselor for patients, pharmacy in the hepatitis clinic should be there, and identify new cases. The World Health Alliance, No Hep, all these have adopted the slogan, find the missing millions. And this is very, very important. As I said, around 90% of people infected by hepatitis B and C, they don't know that we are having this infection. So find those millions. This is already, I said, 90% of HBV, 81% of HCV people, they are unaware of the disease. Many years ago, I published one article, how to make the Pakistan hepatitis free. And I had suggested 2 main ways of the screening, and still it holds good. One is the mass screening. Mass screening is that on the first phase, you screen the high-risk people. High-risk people, those people who live in the highly prevalent areas, those people who live in the areas or in the families where hepatitis B or C has been found. These are the people who by profession are at the high risk. So screen them. And when you screen them, you found them, you link them to cure. And if they are negative, so vaccinate them for hepatitis B. Second phase, people residing in the high prevalent areas and rest of the general public will be the third phase. And second is mandatory screening. Mandatory screening at the time of admission to school, making NIC, making passport, going for employment, going for out journey like Hajj, something like that. So we have to find these missing million by these methods, by mass screening as well as by the mandatory screening. And mass screening will be in the first phase high risk, then the second phase, and then the third phase. So I understand and I believe that the elimination by cure and missing the find the missing millions, it is not a job of an individual or any organization by its own or the government by its own. This is a joint effort. Until and unless the government, the organizations, the individuals, the civil society, they are on the same page, they've got the same targets, they've got the same thinkings, it will be impossible to find the missing millions and go for and strive for the hepatitis elimination from our country. And I think this is the way forward, that we should go for those 80 to 90% who are knowing, who don't know, and we don't know that these are the patients of hepatitis B or C. Thank you very much once again for giving me the opportunity to share my thoughts to you on this topic. And now I'll stop my share and I'll give my mic to the moderator. Thank you very much.
So our next speaker is Professor Muzzafar Lateef Gill. He is an American diplomat of medicine and gastroenterology. He has previously served in United States for 14 years. His publications in international and national journals are close to 75. He has been awarded Sitare Imtiaz for his extraordinary contributions in the field of gastroenterology. He is currently the Chief of GI Division at PF Hospital. His talk today is on hepatitis B management, guidelines, and the real life. So I would request Professor Gill to present.
Well, thank you, Arslan. It was rather overdue introduction. And ladies and gentlemen, chairpersons, what I'm going to do is walk with you for two patients in our real life we saw, and discuss with you. Basically, one is the acute viral hepatitis B and other is the pregnant lady. So this is our Pakistan Air Force Hospital. This is tertiary care hospital in Islamabad and catering both Air Force personnel and the civilian population. This is a 70-year-old gentleman who is a retired civil servant. Came to our outpatient facility in June of 2016. He was known diabetic, was complaining of some weakness and loss of appetite. There was nothing remarkable on his examination. Ran some blood test, and as you can see in this slide, he has picture of mildly elevated bilirubin, but his AST and ALT was high, suggesting transaminitis, that he has inflamed liver. Abdominal ultrasound was showing some steatosis. Considering these raised liver function tests, we decided to run viral screen, and he was surface antigen positive. He had IgM antibody positive, and his DNA was high. So we labeled him acute hepatitis B. So 70-year-old gentleman, diabetic, and picture of acute viral hepatitis B. Should we treat this individual? And if yes, with what medication? Interferon or nucleotide analog? So ladies and gentlemen, what's the appropriate definition of severe acute hepatitis B. It's a recent onset of jaundice with coagulopathy. And if we treat these individuals in severe acute viral hepatitis with this medication, whichever is nucleotide analog, there is a downside. They do not get, their rate of seroconversion for surface antigen is low. So why we want to treat acute viral hepatitis B patient? We just want to make sure that they have good quality of life and they do not go on to chronicity. And in general, as Professor Farooqi mentioned in his talk, 80 to 95% people, adults, with viral hepatitis B, they recover. They do not go into chronicity. And they basically do not need treatment. But the individual or patients who have acute viral hepatitis with coagulopathy and raised bilirubin, they need treatment, or even sometimes we have to do liver transplant. Actually, we did not treat this individual. He was holding on himself. There was a discussion with the family, went home. And then he returned after 6 months with this picture. So of course, he went from acute viral hepatitis, recovered symptomatically, but developed chronic hepatitis B. So it's a little unusual. I wish to go through with you what's the chances if you have exposure to viral hepatitis and how many age group or people will go into chronicity. Neonates close to 80%, infants 60%, children 20%, and adults. Incidence of developing chronic hepatitis B is very low. I just wish to share with you this finding. If your patient have acute viral hepatitis and he is male, above 50, and asymptomatic, the rate of chronicity is higher. HIV positive individuals have higher rate of going from acute to chronic viral hepatitis. Ladies and gentlemen, I wish to share this new nomenclature for chronic hepatitis. Previously, we used to call immune tolerant and immune reactive, but now we talk about hepatitis B is divided into two categories, E antigen positive and E antigen negative. And then we talk about chronic HBV infection or chronic hepatitis B. We need actually three things to understand whether we are dealing with infection or hepatitis. And that is surface antigen, E antigen, DNA level, and liver health. As you can see in this slide, if you have high surface antigen, E antigen positive, DNA is more than 10 log 7 international units, and liver health is normal on FibroScan or APRI or FIB4 score. So we call them chronic infection. There is infection, but there is no inflammation or damage to the liver. If these all parameters change into some high ALT level and there is some damage to the liver, we call it chronic hepatitis B. And same holds true for E antigen negative people. So we divide in 2020 hepatitis B into two categories, E antigen positive, E antigen negative. Differentiate between infection and hepatitis is we do three numbers, and especially if everything is raised but ALT is normal and liver parenchyma does not show any damage, we call it infection. If there is high ALT and damage to liver, we call it hepatitis. So this gentleman came with chronic hepatitis B, what we should do for him. Shall we do a liver biopsy, fibroscan, or without fibrosis assessment? So ladies and gentlemen, it's very important. We need to understand the liver health of the patient. Fibrosis and cirrhosis, we have different categories of treatment and then the duration of treatment. Liver biopsy is usually not done unless you're considering some liver storage diseases or some other problems. So this is European Association for Study of Liver Diseases guidelines for chronic hepatitis B. Any patient who is E antigen positive or negative, who has more than 2,000 international units of DNA, ALT up twice upper normal, and some degree of fibrosis or necroinflammation on the liver needs treatment. All cirrhotic with hepatitis B needs treatment, and if you have family history of hepatocellular CA, regardless what your liver health is, if you are PCR positive and ALT is normal or high, you need treatment. So what are the antiviral agents available to us? There is long list, but practically speaking, there are 3 drugs, TDF and Entecavir and TEF. Both have efficacy, advantages, and I will walk with you which one we should be using and why. If you have circumstances where patient have Entecavir, tenofovir before, it will be more appropriate choice for telfenamide if your patient is elderly, as our individual was. He has bone disease like steroid use, and if there is alteration of renal function. In 2020, telfenamide, TF, is the drug of choice in these groups. So as you can see, the elderly, cirrhotic, people who are osteoporotic and who has renal impairment, this is a study where showing telfenamide versus TDF and bone mineral density, hip and spine. It's better if we use TEF versus TDF. And this is the slide showing GFR level, how with TEF they are better than TDF. Coming back to our patient, remember he came to us in 2016. TEF was not available. We started him on Entecavir. He did very well. And in a year follow-up, his LFTs are normal. And now, as we speak, the gentleman is 74. He is doing very well, and he is on TEF and staying free of trouble, no cirrhosis, and he does not have any hepatocellular CA. So, ladies and gentlemen, this is the first case I was talking, acute viral hepatitis in 70-year-old individual. So we should not be forgetting age and then choice of our medication. I wish to quickly go through with this 27-year-old pregnant woman. She came to us, she was 16-week pregnant, and this is her liver profile. She was basically positive for PCR and LFTs were within normal limit, and her clinical examination was unremarkable. How we manage? As Professor Farooqi has mentioned, ladies and gentlemen, that perinatal transmission, mother to child, infant, is 90%. So this is the biggest route of transmission of hepatitis B. We should be very careful about. And 90% transmission, and newborn and infants, they both have high rate of turning into chronic hepatitis. Then if we do HBV vaccination, and as you can see, incidence of E antigen positive and E antigen negative individual, and blue line is placebo and orange is vaccine. So there is a remarkable difference. In E antigen positive population, it's very effective, but E antigen negative, the question of vaccine is rather not very helpful. So if we want to prevent mother to child transmission, combining HBV vaccine with HBig, again, it's very good, but still close to 20% people still get hepatitis B. Again, I'm showing with you HBig with vaccine placebo. It's very helpful, but this is not the complete answer. We should not be forgetting if we are giving vaccine and HBig and think the day is done and we are celebrating victory. It's not the case. The mother who have high DNA level, their incidence of transmitting hepatitis B to their infants is very high, as you can see. So who are the individual who are high risk to transfer virus to infants is E antigen positive mom who have high maternal DNA level. If we give even HBIG and vaccine, up to 20% vaccine failure, especially in E antigen positive. So let me recapitulate, ladies and gentlemen. If your patient, pregnant lady who is E antigen positive and high viral load, even if we give them HBIG and vaccine, there is 20%, which is a big number, that they can transmit virus to their infant. So what we do with those patients? We have a history of treating pregnant women with hepatitis B. Lamivudine was the first drug used, but it has high incidence of resistance, and same was with telbuvudine. In 2020, the only drug we should be using is TDF, tenofovir, nothing else. So this is antiviral therapy to reduce mother-child transmission, and I'm showing lamivudine. Blue is control and orange is the antiviral. And as you can see, the most effective drug is tenofovir. I still see some patient on telbuvudine for some interesting reason, and it's not very safe in terms of resistance. So as the study showed, tenofovir should be the. So ladies and gentlemen, in summary, when we deal with acute hepatitis people, we should be keeping B in mind. Progression from acute hepatitis to chronic hepatitis B is more common in older adults, as I have shown you the individual 70-year-old civil servant I shared with you. Therapy in acute hepatitis B is very challenging. It should be individualized. These are the 3 drugs we can use, but drug of choice should be TEF, telfenamide, and entecavir for elderly individual. Long-term nucleotides can suppress your virus load. They reduce inflammation and fibrosis, reduce the risk of hepatocellular disease and liver-related events, reduce mortality. Safety and long-term therapy should be considered when we are giving drugs to elderly individuals with renal problem and osteoporosis. And I thank you so very kindly for patient listening.
Thank you very much, Professor Gill, for an elaborative talk on hepatitis B. We have few questions from the audience. First question is from Professor Javaid Farooqi, that what is the role of antiviral in hepatocellular cancers in hepatitis C? Professor Altaf, can you please give comments that what is the role of antiviral in hepatitis C in hepatocellular cancers?
Thank you very much for the question. It is very, very important. It has been suspected for a long time that use of these drugs in patients who already have HCC can accelerate the growth of tumor. So a small tumor can become bigger in a very short time. There was some thought as well that those livers which do not have tumors may develop tumors on treatment. This second point has never been proven in larger follow-up studies from all over the world. But the second point is still true, that excluding HCC prior to starting treatment is of extreme importance. And for that, you certainly need a good quality ultrasound by an experienced ultrasonologist and alpha fetoprotein. If there is any suspicion that your patient has HCC, please do not start treatment. First, treat the HCC either with liver transplant, resection, or palliative treatments like TASE, microwave ablation, radiofrequency ablation. And if you have ablated the tumor or removed the tumor completely, then go for the treatment of hepatitis C. But having said that, please do not stop therapy that patients with livers which do not have existing HCC will develop a tumor. It will give a negative message and will not help the cause of elimination of hepatitis, particularly hepatitis C. Thank you very much.
We have one more question. Yes, please.
May I add to this? Provided if you started a patient with antiviral treatment and in between on the first month, second month, you found that there is suspicious space occupying lesion. Again, I'll second Professor Altaf Saab that continue complete your antiviral treatment if the patient was already on antiviral and do workup for that. If suppose on one in between ultrasound told you that or gave you some suspicion, don't stop. Complete that 3 months or if it was cirrhotic 6 months. But of course, before embarking on antiviral treatment, it is mandatory that you actually exclude any doubtful lesion, any suspected lesions. But and this is that if you treat that successfully, definitely you minimize the chances of HCC to almost to the general population, though you don't make it zero, but these are the minimized.
I think it's a very controversial subject, as Professor Alam has mentioned. When your patient has developed HCC, basically horses are out of the barns already. And as Professor Alam has mentioned, sometimes giving antiviral, we enhance the tumor. So it's a very delicate way to handle this. But sometimes there are, few reports and studies suggesting they continue the treatment, others are opposing it. So it's not very easy situation. I will revert back to Professor Alam. If I understand right, we should be a little bit cautious continuing treatment antiviral in HCC individuals.
Agreed. On a personal note, I always stop therapy. HCC takes priority. And once I have completely either ablated or cured HCC, then I revert to HCV therapy. So this is my personal, there are no guidelines. So whatever you are doing, think of patient safety and patient's life expectancy first, and do what you are doing for your patient. Thank you.
Okay.
We have one more question. If a patient with F4 fibrosis, hepatitis C positive patient, so what is the risk of worsening of liver disease on antiviral treatment?
Can you repeat the question again?
Well, you see the cirrhotics, we divide them. We all know that the compensated, decompensated. Of course, when it is decompensated at present or post history of decompensation, the MED scoring and all those things, they are very important, and we should be very careful. But with well compensated F4 with no prior history of decompensation, antivirals, it's the urgency and they must be treated. But with close monitoring, this is very important. But if your patient is decompensated, if even in the high volume centers, before embarking on the antiviral treatment, we do try to improve their status, to improve their child scoring. And we can improve the child scoring by effectively treating the ascites, by preventing the HE, improving the nutritional status. So but for the general primary care physician, and general physician, if your patient is cirrhotic and especially decompensated, please don't start antiviral treatment. Refer that patient to the center where such patients are being treated, because if the delay happens here, it is the only option is then is the liver transplant. So this is one should be very careful.
I think I would like Professor Alam again, but I have one little suggestion here, Farooqi Saab. The question was fibrosis, can it be reversed? And as you know, if we do fibroscan and if it's F2-3, there are many studies, people have started treatment, and then after completion of treatment and PCR negativity, check the fibroscan and their kilopascal value was low. So there is some chance if you are like kilopascal 12 to 14, if you were 17 and above, as you have mentioned. So then reversing cirrhosis back sometimes is difficult. The other thing, decompensated cirrhotic, it's a very hard topic these days. some authorities believe we should treat them, that you want to arrest the progression of cirrhosis onto HCC. But I am requesting Professor Alam again for his view, especially decompensated cirrhotics. In my view, they should be treated with carefully under very close follow-up, experienced people, but I would welcome Professor Alam's view.
Yeah, the general guidelines recommendation are very clear that decompensated cirrhotics should be treated in centers where liver transplant facility is available. But having said that, how many liver transplant centers exist in Pakistan? So that's a difficult guideline to follow. But one thing is very clear. If your child P score is more than 12 and your MELD score is more than 20, 18 to 20, then this is a no-no case. Liver transplant first, then the treatment of hepatitis C. But less than that, yes, all patients with decompensated cirrhosis, we are happy to have the oral drugs and they should be treated. And there is some evidence in literature that both decompensated and compensated cirrhosis reverts in at least 30 to 40% of patients to less severe fibrosis and less state of decompensation. So with oral drugs, we are fortunate that we can provide help, but then there is a limit to everything. And if your patient with decompensated cirrhosis has a CPT of more than 12 and MELD score of more than 18, then it's a too far case. Transplant first if one can, and treat later. Thank you.
I have one more question, and that is for Professor Hashmi. I think he is closing his eyes, dozing off. Maybe for Zahid and Professor Alam both. You see, decompensated cirrhotics, they keep us saying, you know, we should be giving this combination with ribavirin. And this is the group which is very difficult, to treat and give them ribavirin. So I'm just asking Professor Zahid to you first, what's your experience? Because I'm not having much luck. They come with bleed, low hemoglobin. So my patients are sometimes, I think audience understand Punjabi, they are from Gujarat and Mandi Baudin. And Choi Saab, pehle nalon bhi gal bigad gayi hai. You use ribavirin in decompensated cirrhotic along with your sofosbuvir and other combinations. I think we have difficult.
Zahid साहब unmute करें अपने आप को please.
एक करी इधर से करना है या वहाँ करना है?
जी मैंने कर लिया जी.
You were able to hear what I was asking?
I did hear. Thank you very much, Gill sir. This is absolutely true that patients with decompensated, more advanced and end-stage liver, they do not normally tolerate ribavirin very well. So what I normally do, if their hemoglobin does permit me, I may start with a very small dose, say maybe something like 400 milligram. And as the time passes, and if I find that they are tolerating it well, I may titrate it upward. But usually, most of my patients, they do not go beyond 800. In fact, majority would be, close to 400 or 600 milligram.
Altaf, you have thoughts how to handle this? I'm never able to go beyond 400 milligram. The moment we go up, we are in difficulty.
Yeah, you're right. These are difficult patients to treat. I tend to always give them ribavirin. But, one thing more, I would say that I try and improve their clinical status if I can. Like if they are iron deficient or B12 deficient, I work on this and try and improve that upfront. If there is no cause. It is just decompensated liver, splenomegaly, bleeding, whatever. Then, like Professor Zahir Yaseen Hashmi has mentioned, that starting with a lower dose, following them very closely and calling them back maybe every 10 to 14 days, looking at their hemoglobin and either reducing or increasing the dose as appropriate is the only answer. If you can't give ribavirin at all or effectively, then the only other solution is increasing the duration of treatment like SOF and Velpa to 6 months rather than 3 months. Thank you.
Professor Mauzam, you have the same problem in Quetta. You know, Western European American guidelines and our ground realities are very different. Our patients come from far-flung areas. Monitoring is challenge, and I'm posing this question to you. You face this difficulty in your practice and how you handle it. Everybody is able to hear Mauzam?
No.
He is muted, so please kindly unmute yourself, Mauzam Saab.
आप स्मार्ट लॉकडाउन में तो नहीं चले गए? कोई
Still
और
mute.
क्वेश्चन है?
Sir, we have one more question from Professor Javaid Farooqi, sir. The question is a patient who multiple times first interferon, then he took Sobasvavir and Declesavir, then he relapsed again, then he took Velpatasvir and Sobasvavir treatment, and his early child is cirrhotic right now. So what would you recommend now? His PCR is still positive.
Well, thank you. So far as I understand, this is a man who was relapsers to interferon and then to soft Decla, and now the patient has been started on soft Velpa, and he is a child class A cirrhosis, compensated cirrhosis. This is what the question is.
His PCR is still positive after 3 months.
Okay, so he is now a non-responder to the 3 month therapy of soft Velpa with Riba or without Riba. This is what should be important. With Ribavirin. Okay, so yes. You see, the treatment with the DAs is I mean, it's some sort of very tricky one. The thing is that those patients who respond, they respond within 1 month rather than within 1 to 2 weeks. This should be okay. So if a patient is non-responder after 3 months, I wonder that if we extend this therapy for 6 months, and will we be getting any benefit here or not? So one is that, of course, we should be excluding the causes of the, compliance and all those things. And second, this is a patient where it is really, this is the C mono infection, or maybe the BC co-infection as well. It should be actually excluded. If not, then we have got the options for the Voxy, Oxy for the GP. These are the other options, but these are not available over here. So one point is this. I'll be just adding to previous 2 questions, one line each. One for the Professor Lateef Gill Saab. Yes, that was the fibrosis, because we are doing this fibroscans since 2012. And we have found that, yes, the reversal of fibrosis is possible, but if the baseline fibrosis was low, reversal is very, obvious. And if it is high, then it is low one. And second is the treatment of the decompensated cirrhosis, a very, common problem. Problem in this, you see, when you treat the HCV patient, this is the first month where the viral dynamics, they matter. And what we have found, that this is the first 4 weeks where your Riba and all those, that matters. So I had this, that I started this patient with low dose Riba, and believe me, that was not that good response. So what now I'm doing, I'm following the protocol which Professor Altaf is doing, that we try to improve their general health. We try to dry up their ascites, make their CT scoring improve, and then we give them at least 800 milligram. And this is the initial 1 month. I still say, if the patient can tolerate for 4 to 6 weeks or 8 weeks, and then if you lower down the dose and increase the soft Velpa. So here you have to individualize the therapy. And in this very patient, probably extending the therapy to 6 months will make no difference. If that patient was non-responding to so many drugs, better is wait for the other drugs to come. Meanwhile, follow up these patients for worsening of the liver cirrhotic status, development of any HCC. This is all important. If the patient can afford, then the patient can import the drugs and go for that. This will be my suggestion for this very patient.
Arslan, Mauzam Saab is now ready to answer that question of use of ribavirin in his patients in Quetta. Ji, Mauzam Saab, can you hear us now?
Yeah, we use and monitor the patient, but in very low doses. And I agreed with you and Gill Saab that we should monitor the patient, and after fibroscan is not available in Quetta, patient goes towards Karachi or Rawalpindi. That is the main reason. Then we only monitor the patient and our other good ultrasound, and after that we start in low dose.
Altaf, I have a question. You know, this patient who has exhausted all available options apparently for Hep C, what we have in Pakistan, like SOF, Well, and Riba together. They are not very common, but you know, we all run into those kind of patients. And the other thing is this new drug, which is very costly and not available. So you have some brilliant ideas how we should go about it. Patient comes with whole host of previous treatment, including SOF, Well, and Riba. One is the Farooqi mentioned co-infection with B and compliance, but any magic formula?
No, I don't have any magic formula, but Wasavi is now available, SOF, Well, and Voxilapravir is
Yes.
a triple drug is available on with one of the companies, and one can request it for special patients. So now it is available, and this mild cirrhotic preferably should be treated with Wasavi. But if that is not an option, and he has been treated in the past with a 6-month treatment of soft DACLA and ribavirin, and Wasavi is not it was not available at that time. I have treated some patient with soft Well, Riba with close monitoring, increasing the duration of treatment to 6 months, and I would say that more than 70% of them have responded. These are limited numbers, as you say, but certainly soft DACLA failures have been treated with soft
Yep.
Velpa and Riba for longer duration of period.
Arslan, you have more questions?
We have one more question from Professor Gill, that in hepatitis B patient cirrhotic, as you have mentioned, sir, regarding the new medicine telfenamide, so what is your recommendation according to guidelines? What would you recommend in patients with cirrhosis? What is the best medicine for hepatitis B?
You see, this is new drug and we are learning. And initially the question was, is it same efficacy wise as the previous two in TECA and TDF? There are some studies, but I think we should be cautiously optimistic about this drug. We still need to learn more. However, if you have your patient who are 60 and above, who have some osteoporosis or some renal function issues, in my own, you know, as we see patients together, you see, I have not seen, I would welcome Altaf and Zahid view, this tenofovir related renal function issue or GFR. Initially, it was touted some tubular defects and, you know, deficiency of minerals. But I can count maybe 3-4 patients in the last 3-4 years. So TDF was reasonable. There is sense of preference that it has more potent, so to speak, HCC suppression activity versus entecavir. But I think if you are able to closely monitor your patient, we have close to 50 now on TEF and they're doing very well. So in summary, if your patient is above 50 or 60, depends what's the age of the treating physician. Being old and old adult is very interesting jargon, Altaf. And if 50 and above and some renal impairment, I certainly consider TEF instead of the other two. What would you say, Zahid?
I think before I say anything, let me tell Gill Saab that if somebody calls 50 and 60 as elderly, it hurts.
In
And very soon,
Punjabi, they say, "Bade young lag rahe ho."
very soon it is going to hurt you as well. And I think we should elevate
I'm ready, brother.
the age limit needs to be elevated.
As I already submitted very humbly, it depends the age of the treating physician. आप फिर बार ऊपर लेके जा रहे होते हैं ना कि how much is old.
But I think I totally endorse your point of view that we have been using TDF for quite some time. And it is true that if you see literature, it does affect bones, it does affect kidneys. But if we monitor them and monitor them frequently, say maybe at yearly interval or 2-yearly interval, most of the time there is no issue. But in our setup, what happens is when you tell your patient of hepatitis B that this is the medicine which you're going to take for a very long time, they sometimes don't return. And they may return years and years later. So that is a big issue. So from that point of view, TAF is certainly a better option in a setup like Pakistan, where follow-up sometimes is a real issue.
Agreed. Agreed. We have been using TDF for a very long time. Primarily, I've not seen TDF-induced renal impairment a lot, but there are patients who are presenting, particularly males more than 65, females in the post-menopausal period for the first time, and those who have existing bone disease and CKD due to other reasons rather than TDF.
Yes.
So now we have a choice where we can use this safely, particularly when the renal failure is minimal, the creatinine, the CKD 1, 2, 3, we can use these TAF. And I tend to use in more than 65 postmenopausal women and those with bone and kidney disease due to one reason or the other. But yes, TDS-induced renal impairment has been seen very rarely by me as well. Thank you.
Dr. Arslan, may I add just one point? Probably the question was the HBV-related cirrhotic. So if our patient is cirrhotic, if it's a compensated cirrhosis, I think the TAF has been recommended there. But if it becomes a decompensated, it's with a double-edged sword. On one side, the decompensated cirrhotics, they are having this liver osteoarthropathy and all those things, and the impairment as well, where TDF is really very cautious. But in decompensated cirrhotics, TAF has not been recommended. And if you are either, you've got two options. One is entacavir, one is TDF. TDF is in the regular dose, but with the proper, very close monitoring. And if you are using entacavir, you will have to use it in a double dose, 1 milligram. So this is some sorts of cage point in cirrhotics that we should be careful in cirrhotics. Otherwise, in cirrhotics population, especially the, I won't be saying the elderly, they are more than 50, 55 years, post-menopausal, all with renal impairment. I think TAF is the option. But after saying all this, I have found TDF very safe. Believe me, in a very, normal people, I have very rarely come across these renal problems or all those things. Or maybe we are not doing these regular bone scans or something like that. But still, if it's a high-risk population, then of course it should be going for the TDF. And one is that the TAF, sometimes people ask me in pregnancy also the TAF is not, recommended. It is only the TDF.
only drug in pregnancy in 2020 should be TDF, period. Nothing else. I have one question for Professor Altaf. You know, Americans are blunt, and their president is even more blunt. They say E antigen negative chronic hepatitis B. You are committing your patient lifelong. So, what's your view on oral drug for chronic hepatitis B E antigen negative?
Well,
Till they
yes,
lose surface antigen,
yeah, uh,
S loss.
yeah.
So, how
So
you
practically, as we see it, it is lifelong treatment. There are certain patients, and I have two patients in whom I have treated E antigen negative disease, and after 3-4 years of negativity of DNA, surface antigen is still positive. They want to get rid of therapy. So you need to sit down and talk to them that yes, there is a now a escape route. We can stop treatment, but you need very close follow-up. So you need to come every month for 6 months, and then every 2 months for the next 6 months, and then every 3 months for the next year, where we need to follow your liver function tests, surface antigen, and also viral load. Most of them, as you know, will go into a flare. The virus will reactivate, but there is a good flare and there is a bad flare. So one has to recognize that, and that is where the art of hepatology comes in. There is no medicine in it. And only very experienced people can differentiate between a good flare and a bad flare. All of them, more than 75% will go into a flare. So if we think that it is a good flare where the patient is doing well, the ALT is not gone more than 10 times upper limit of normal, the viral load will always be high, bilirubin hasn't gone beyond 1. These are the patients who may lose their surface antigen. And out of these two patients, I had to restart treatment on one, and the second patient lost surface antigen with a good flare. So that is why the guidelines, international guidelines, now recommend that E antigen negative disease non-cirrhotic patient. It is important to remember that non-cirrhotic patients may be taken off treatment if they have DNA negative for 2 to 3 years, but these patients require very, very close follow-up to differentiate between a good flare and a bad flare, and what to do next, whether to restart or to carry on follow-up. Thank you.
Altaf, the reason I raised this question is that I have been burned few times. You know, the patient get PCR negative and liver function normal, and Farooqi for you as well. And you know, you still tell them keep taking medicine, they disappear, and at least 3-4 patients last year came back and they have hepatocellular CA without cirrhosis. And one of them was very close friend, engineer by profession, and I had very hard time. So I think in general, would you agree that we should be giving maximum duration of treatment to E negative? Fibrosis, cirrhosis is lifetime commitment, but even male above 50 who they have fibrosis regardless. Farooqi, what do you say?
I totally agree with you. One or two of my very close, friends, just like yours, they had developed this problem, the hepatoma and all these things. What I say that, you see, we also learn by, the patient's attitude and all those things. Now, when I start a patient's on hepatitis B treatment, I tell them two things. One is that it's just like hepatitis and diabetes, lifelong treatment. And second, I tell them that our aim is your HBs antigen negativity. And I know that never becomes negative. So it is automatically, when they comes with me with a report, sir, मेरा PCR तो negative हो गया. मैं कहता हूँ अब एक चीज तो रह गई क्या, जो आपका HBs वो तो जरा करा क्या, अगरचे उसने कि मुझे पता है वो positive होगा, ये बस इंशाल्लाह ये भी हो ही जाएगा. I think these are the patients who really need a regular counseling, sorts of encouragements and all those things. And because अगर आपने कह दिया कि जी आपकी ट्रीटमेंट पूरी हो गई, तो मसला होता ये है कि वो फिर आपसे they disappear, and when they come with a very bad shape, either cirrhosis or hepatoma, ये तमाम चीजें. तो मेरे ख्याल में कि this is a very tricky questions, and that's the reason when I delay the treatment for the reason the patient is not qualifying for, वो कहते जी क्यों शुरू नहीं करना. मैंने कहा अगर लाइफ लॉन्ग मुझे लिख के दे रहे कि मैं दवाई ले रहा हूँ तो लेता रहे जी. ये तो, या फिर मैं ये भी आजकल कहता हूँ कि मे भी 1-2 साल बाद कुछ ऐसी दवाइयां आ जाएंगी जो कि आपकी ट्रीटमेंट डेफिनेट हो जाएगी. आई मीन होप तो है. तो ये ट्रिक्स करनी पड़ती हैं एट द लेवल ऑफ द पेशेंट अंडरस्टैंडिंग कि वो जिस तरह समझता है.
यू प्ले पीटीआई विद देम कि 1 साल ठहर गए हैं, अगले साल खुशहाली आएगी. अरसलान कमेंट्स ले लें प्रोफेसर तीनों को. हाँ, है क्वेश्चन?
I have a question from
Sir, one last question.
प्रोफेसर जाहिद का क्वेश्चन ले लें. जी जाहिद.
I have a question with Professor Farooqi that we have been talking about elimination of hepatitis C and so forth. So is that really achievable? Or we would just be managing, control of the disease? Because some of the aspects you have already highlighted, and there were quite a few which in some of our previous meetings, Asad Chaudhary, for example, he carried out a kind of a micro-elimination in a suburb of Gujranwala. So did we, and try to duplicate that in some of the villages of Faisalabad. And we found so many other issues which generally we don't think about, because when you are actually involved in it, the ground realities tell you that probably there is a lot of reluctance on part of the patients as well, particularly when the disease is asymptomatic as it is in the early, years. So is that elimination really achievable?
Thank you, sir. बहुत ही relevant point, a very relevant point. You see, one of the slides मैंने global response आपके साथ share किया. उसमें एक component ये था कि those states who involved the civil society, उनके जो targets थे, उनके जो issues थे, they were much higher than those where the government policies were being implemented. We have got the Egypt model with us. उसमें भी यही है कि they have mobilized whole of the community. You see, अगर हम उसको technically जाएं, वही है कि the pool of the HCV, it comprises high risk areas या वो families जहाँ पे ये patients हैं, वहाँ पे ज़्यादा chance रहता है. तो until unless it's a multifaceted. हमने इसको मुख्तलिफ साइड से इस पे अटैक करना है. एक तो वही जिस तरह मैंने कहा कि हाई रिस्क को हमने टारगेट करना है, चाहे वो यस एटीट्यूड, पीपल एटीट्यूड इज वेरी डिफिकल्ट. अगर आप उसको मुफ्त दवाइयां देते हैं, वो कहते हैं इसमें कोई इनका अपना कोई मकसद है. ये चीजें चल रही हैं. हाँ, तो ये जो हुआ कि जी ज़ार का टीका लग रहा है, लोग कोरोना को मार रहे हैं, मैं कहता हूँ अजीब सी बात है, हुकूमत 1 लाख रुपए भी दिन के लगा रही है, ज़ार का टीका भी आपको लगा रही है. तो चीजें ये हैं कि यस, our people, they have got a very thick meninges, thick, बहुत जो है उनके जो है वो thick barriers है, blood brain barriers है, बात उनमें घुसती नहीं है. लेकिन still having said that, हमने फोकस ग्रुप्स करना है, माइक्रो एलिमिनेशंस पे भी जाना है, हमने सोसाइटी को मोबिलाइज करना है, हमने इसको इसको फैशनेबल बनाना है. HIV के कितने केसेस हैं, कितना उस पे हाई चल रहा होता है. इतनी जो है ना, हम भी फेल हो गए ना, हम सेलिब्रिटीज को ला सके ना, हम उनको जो है ना एक हाई चीज पे ला सके. तो हमें करना होगा, गवर्नमेंट को भी, सोसाइटीज को भी, इंडिविजुअल लेवल्स पे भी. दिस हैज टू बी, इट्स अ वेरी डिफिकल्ट टास्क. लेकिन एलिमिनेशन बी के मुकाबले में इसी की बड़ी आसान है, बाय क्योर, क्योंकि इसकी क्योर मौजूद है, बी की क्योर नहीं है. तो मेरा ख्याल में कि दिस इज अ वेरी वेरी चैलेंजिंग. एंड चीज ये है कि अगर हम अपना टारगेट रखेंगे 2030 और होप्स लूज नहीं करेंगे और अब इसको रिविजिट करते रहें अपनी पॉलिसी को। मैं जब ये अपनी प्रिपरेशन कर रहा था, जो लास्ट ईयर जो हेपेटाइटिस डे था, उस पर कुछ एक गवर्नमेंट का प्रोग्राम आया था, मैं उसकी डिटेल में गया, बातें बड़ी हुई थी, लेकिन जब देखा तो हुआ कुछ भी नहीं है। तो बात ये होती है कि हमें इसके लिए प्रॉपरली लोग प्रॉपरली उसमें जो इन्वॉल्व हो गए, जो समझते हैं, उनको लेना होगा, बजाय इसको बाय इन टर्म्स ऑफ की यूज की कैलिबर बढ़ाए, कैलिबर नहीं, जो इसके लिए है, जो समझता है। अनलेस ये ना हो, मेरे ख्याल में आई एग्री विद यू, दिस इज वेरी नेक्स्ट टू इम्पॉसिबल, ये मिशन इम्पॉसिबल 5 होगा, लेकिन ये कि वी हैव टू वर्क ऑन इट, क्योंकि ये टारगेट है ही ऐसा है। आई थिंक इट्स अचीवेबल, लेकिन अगर इसको प्रॉपर तरीके से और अपनी पॉलिसी को रिविजिट करें। अब तक जो पॉलिसी रही है, आई एम सॉरी, वो ऐसी नहीं रही है कि हम कह सके कि ओके 10 साल बाद भी अच्छा हो जाएगा, शायद इससे बुरा होगा। आई टोटली एग्री विद यू।
थैंक यू।
ओके
जी, थैंक यू वेरी मच ऑल फॉर दिस क्वेश्चन आंसर सेशन। लास्ट में मैं जो हमारे एक्सपर्ट्स हैं, सबसे पहले प्रोफेसर अल्ताफ से कहूँगा कि वो कंक्लूडिंग रिमार्क्स दें रिगार्डिंग दिस होल सेशन। प्रोफेसर अल्ताफ, can you please give your
Thank you.
comments, sir?
Thank you, Arslan. A wonderful session. Thoroughly enjoyed it. Two very good talks. One relating to hepatitis C elimination, which is very close to our heart, and the other one by Professor Muzzafar Lateef Gill. He always makes it very easy on a very difficult subject, and I thoroughly enjoyed listening to the speakers. Very pertinent questions asked in the question answer session, and on a personally, I thoroughly enjoyed it. Thank you very much.
Thank you, Professor Altaf. I would request now Professor Zahir to opening comments. Please, sir.
Thank you, Arslan. Thank you very much. I think it was a privilege to be part of this program, and there are so many added attractions. You see friends, you listen to them, and simultaneously, by listening to the two very, very eminent and wonderful listeners, it improved my personal knowledge and information as well. And then, as Professor Altaf Alam has very rightly pointed out, a very useful question-answer session. I'm particularly grateful to GETS Pharma as well for making all this possible, that we could attend such a wonderful session. Thank you very much.
Thank you, Professor Said, for your wonderful time. Last में मैं Professor Mauzam से कहूँगा कि वो अपने remarks दें, please.
First, I am very thankful to GETS Pharma for their invitation and arranging such like session on hepatitis, World Hepatitis Day. Professor Farooqi gave a very comprehensive talk on hepatitis, and I want to add something, but I agreed with his point. And if we want hepatitis, elimination, we need strong financial and political commitment, and also support from civil societies and support from pharmaceutical and medical companies around the globe. And second important point, which discussed by Professor Farooqi, universal screening once in a life. And I think universal screening should be done, but screening is the only mean find
Arslan, मेरे रहने दे बस ठीक है।
and provincial and local bodies, government should play their role effectively and must work in close liaison.
आप इसको conclude
We arrange public awareness program, and government should play its role effectively and firmly. And this is I think financial support mandatory by the government to screening work of and management of hepatitis patients, and government should devise a strategy to cut down subsidized cost of workup and management of hepatitis. And I think this is a teamwork, and and we should work combined to eliminate the hepatitis by 2030. And I'm also thankful to Professor Gill for his kind remarks, and he gave a very good presentation of cases in which he highlighted very important points. I want to clear one point. In Balochistan, we have not too much facilities of investigation. Even if we want to do PCR quantitative or hepatitis B profile, we send blood sample to Karachi or Islamabad or Lahore. And there is, you will surprise. Till now, there is no fibroscan facility in Balochistan. And this is the main problem. We can observe the patient, monitor the patient very closely for treatment. And what we can do in the limited capacity, we are doing. And once again, I'm thankful panelists and Gas Pharma for a wonderful session, and hope it will be continue throughout year. Once again, I am thankful.
Aap conclude. I think our moderators have some technical issues, and I have just one final note from very core of my heart. Other than science, it was wonderful to see all brothers, and I think Altaf, you are the thinking genius among us. Keep us in the loop, keep us informed, educated. Farooqi, I think, disappeared. I don't see him. I think it was wonderful, and under Altaf, Zahid, Farooqi, and Professor Muzzam, we all enjoyed. And one personal note to Muzzam, I hope all is well. Ask couple of Baloch Sardars to donate few fibroscan.
Yeah, of course.
And I think Pakistan Zindabad, then it was good.
Thank you.
Company and time, and I hope public has learned as well.
Thank you. Take care.